Thank you very much. I will be talking about the ECT practices in schizophrenia. As stated by Professor Musa, this was discovered by Italian physicians for the first time, and afterwards, along with the antipsychotic drugs, ECT practices decreased, but afterwards the efficacy, especially in the drug-resistant schizophrenia, it started to be used once again, and in the latest studies it has been shown that it's quite useful for the schizophrenic patients with suicidal risks. I don't want to talk about the mechanism a lot, but ECT in schizophrenic patients, it has an effect on the structural nucleoids, and this is proved by many studies. And lateral, prefrontal, and singular network in schizophrenia, there is an increase after the ECT, and it is directly related to the clinical recovery from the disease as well. And if we talk about the guidelines, treatment guidelines, in Australia and New Zealand treatment guideline, they made an evaluation of the ECT. For a fast response, ECT should be used along with the antipsychotic drugs, and especially the patient resistant to the drug. If clozapine is not responded well, ECT can be considered, and in the follow-up treatment, progressive betterment might be seen. And for this reason, especially the first ECT, if it is effective and combined with the antipsychotic drugs, at least for 6 months, ECT can be continued, especially in the drug-resistant schizophrenic patients. What does BAP guideline? It is an older one, and it states that the ECT usage is not enough for the schizophrenia treatment, and in the acute episodes of the schizophrenia, they fail to increase the relapse, and Cochrane review, the purpose is to have a fast betterment, and when there is a decrease in the symptoms and with the weak response to drugs, for those patients ECT can be recommended. And World Psychiatry Union Association says that for the patients who doesn't respond clozapine, ECT can be used. ECT plus drug therapy can be used together, and it is more useful for the only pharmacological treatment, and catatonic patients, and we can use them, we can prefer ECT. In this guideline, as a result, summary statements, there is limited proof in terms of the ECT's efficacy in schizophrenia. ECT plus antipsychotic treatment might be appropriate, and in the catatonia it's an important and efficient alternative. Catatonic paranoid and other symptoms reply best to the ECT, and bilateral high dosage treatments might be preferred as a technique, and antipsychotics and ECT along with the clozapine, and also for the usage relapse prevention, ECT can be clarified better with the studies. And in terms of the fields in which ECT can be used, ECT studies date back to the past. Real ECT and placebo ECT, especially since the first usage of the ECT, these studies started. However, in more recent studies, we show that in the ECT period, the real ECT is superior to the sham ECT, in the long run, it doesn't have any advantage. Abraham and Kulhara have a study, and at the end of the 6 months, there is no difference between two groups, ECT and the Shem ETC group. And in terms of practice, bifrontal is superior to bitemporal ECT, and this can be seen in the BPRS scores and functionality scores and the nurse observation scores. There is an important and meaningful difference. ECT indications for schizophrenia, the catatony and also drug resistance, especially in our clinical experience. This is the first reason we go for ECT. If we compare antipsychotic drugs with ECT, antipsychotics might be superior to the ECT, but augmentations, ECT plus antipsychotic, many studies showed that this is better than the antipsychotics alone, especially for the drug-resistant patients. ECT clozapine combination can be used for the patients resistant to the antipsychotics only, and we can see the proofs in the literature. And ECT clozapine combination can be used, therefore it is underlined in some studies. Grover et al. Have a retrospective study, clozapine refractory group, there is a meaningful betterment. And in other antipsychotics, there is a decrease in the PANSS scores, but especially with the clozapine is augmented with ECT, cardiac arrhythmia, and this might be the only effect of the clozapine, and the prolonged seizures, delirium, and cardiomyopathy. There was a warning about these side effects. When we look at another meta-analysis, especially early symptomatic recovery, is about ECT and antipsychotic augmentation. We can see good results in terms of symptomatic recovery. We can see that it's meaningful. And 22 randomized controlled study, it's a meta-analysis, and in the psychiatric symptoms decrease, ECT is increasing that at the medium level, and when compared to the other psychotherapies only with the drugs, ECT has some advantages over that. And response rate and the remission, there are meaningful superiority and advantages of ECT. Again, between 1980 and 2015, the data has been studied, and clozapine plus ECT, 66% recovery was explained, and the general studies show that as well, 62, 72 between, and so it is efficient and safe. And when we look at the similar studies, 67%, 70%, especially when you add up ECT. This is a study conducted by Musa Bey in our clinics, ECT plus antipsychotic. So the patients are in a better condition when they are sent away home. Summer et al. This is interesting, by the way. In the treatment of hallucinations, pharmacotherapy, BDT, ECT, and TMS were compared. Even if there is a general recovery with ECT, no meaningful effect in the hallucinations. Therefore, antipsychotic drugs are better for the treatment of the hallucinations in the schizophrenic patients. And there are many other studies. Catatony, the useful effect of ECT was proved. However, Hatta et al. Study show us that antipsychotics and different antipsychotics and benzodiazepines comparison studies, in the catatony, all the ECT patients recover 100%, but without that, the ratio is not like that. So for the catatonies, that is the first indication. And for the first attack, first episode schizophrenia, it might be efficient for the drug-resistant patients. And in the schizophrenia and schizoaffective disorder diagnosed adolescents, in the 2 years cognitive and side effect follow-up, there is no meaningful difference between ECT and without ECT, and we can think that it is safer.
Also, for Zhang study, regarding Zhang study for schizophrenia, we see that duration of hospitalization goes down, and together with ECT augmentation, there has been significant and statistically meaningful improvement, and this is correlated. And ECT is deemed to be a reliable and tolerable method for adolescents. Early studies regarding suicidal tendencies have shown that there is not a statistically meaningful benefit, and in comparative studies, even if there are no suicidal tendencies, the ECT group, as per Adri study with 5,871 patients, it was observed that there was a lower mortality rate, however an increased suicidal tendency level. Of course, this is a bit of a conflicting data, particularly for long-term monitoring. And there was a more recent systematic review that summarized information from various different studies, and I would like to mention that as well regarding the effect of ECT on schizophrenic patients. In the long term, we see that particularly for treatment-resistant schizophrenic patients, there is some improvement as per the studies. Real ECT is superior, however, in 6-month follow-up, the superiority no longer exists. Particularly for long-term monitoring ECT patients, there is no adverse effects on the psychology of the patients. For first attack psychosis, it's credible and reliable. Glutamine monotherapy, if ineffective on the patient, then ECT can be considered. Frontal ECT I have mentioned, bitemporal compared to bitemporal BCT is found to be more effective. In a study for treatment-resistant schizophrenic patients, it was deemed to be usable, and in terms of efficacy, proved to be superior. And for first attack psychosis, it was reliable, like we have said. So, to sum up, for management of acute symptoms of schizophrenic patients, it's a credible method for increasing quality of life. It's a good alternative for treatment-resistant patients. For hallucination treatment, the effect is debatable. Catatonic schizophrenic patients respond to it better than non-catatonic schizophrenic patients. If there is insufficient response, then it might be considered as an alternative. The combination is trustable and has high efficacy, particularly for treatment-resistant schizophrenic patients. The first attack for younger patients and we see that there are lower side effects as well. During pregnancy, has low risk for the mother and the baby.